Shemai, hello, and welcome to this short presentation on abdominal palpation. My name is Ellen Parker, and I'm going to be one of the lecturers when you attend the Biosci Lab practical over in Park Place, who will be showing you with a model how to do an abdominal palpation in pregnancy. But in the meantime, to get us ready for that, I just want you to go through this short presentation to see what we do and why we do it. So why do we perform the abdominal palpation? Simply that we need to determine that the baby is growing in accordance to gestational age, and also to establish which position the baby is in, ready for delivery. There are 4 key elements to any abdominal examination, regardless of pregnancy or not. They are inspection, palpation, percussion, and auscultation. These are the same in pregnancy, except we do not percuss. So when carrying out a palpation in pregnancy, we follow the mnemonic I flapped. Don't get yourself in a flap about it. I flapped will take you through slowly and steadily. So the first thing is inspection. Fundal height, lie, attitude, presentation, position, engagement, and denominator. We won't go through all of these today, as many of them are used in a specialty rather than as a student. You wouldn't need to know them all, but the ones that are important we will go through. So let's start with inspection. When we're inspecting the pregnant abdomen, firstly we're looking for scars. Scars are indicative of any previous surgery. It may be that she's had a previous caesarean section, maybe a laparotomy or laparoscopy scars. They all let us know what's happened in the past. The linea nigra is a natural line that has formed a darkening of the skin pigmentation that forms along the centre of the pregnant abdomen. It's quite normal. Some women do have it, some women don't. Darker in some women, lighter in others. Rashes are important to keep an eye out for as well. A rash can be indicative of a serious condition in pregnancy called obstetric cholestasis, so we need to be aware of that. But women very often get rashes as the skin stretches. It just becomes a bit irritated and they can scratch it. So knowing about being able to put moisturisers, etc. onto the skin will help her be more comfortable. Bruising again could be indicative of serious conditions of clotting. However, it can also be indicative that maybe this patient is not safe at home. Is there domestic abuse being carried out in the home? Is she and the baby safe? Domestic violence and abuse, we know, either diminishes greatly during pregnancy or escalates massively. So we always ask every pregnant woman on at least 2 occasions, when there is nobody else with them, do they feel safe at home? Are they at risk? And then obviously we just look at the general appearance. Does everything look normal? So we're going to move on now to the actual palpation. The first thing we need to look for is the fundus. We palpate down onto the fundus. So this is if you start at the zippy sternum and palpate your hand down slowly until you feel a ledge. Okay, that'll be the top part, the upper part of the uterus. And this is where we need to find that fundus. Once we have found the fundus, we are able to measure. We use a non-fabric measuring tape, so it doesn't allow for any stretch, and also because of hygiene we're able to dispose of it. Or if we leave a paper tape measure with the woman, so she uses the same tape measure each time. We also turn it upside down so that we cannot see the numbers. This reduces the risk of bias. And we measure from the fundus to the symphysis pubis. You'll notice in the picture we're actually measuring from the symphysis pubis to the fundus. That is actually incorrect, okay? So always measure from the top to the bottom. In years gone by, we used to say that 1 centimetre equaled 1 week of pregnancy, and we'll be able to monitor if that baby was growing appropriately by how many centimetres the abdomen was. This would be, if she measured 36 centimetres, we would expect her to be 36 weeks. If she was measuring smaller at 36 weeks, we'd wonder why that baby's not growing. Or if she was measuring at 40 centimetres at 36 weeks, why is that baby so large? However, we soon found out that this really wasn't very accurate. We've used it for years, But if you look now, compared to 2 generations ago, at A, the size of our mothers, and B, the population mix we have within society, you'll notice that we've got very varied. We're now a global neighbourhood rather than a local neighbourhood. So this is one size doesn't fit all. For example, if your mother has a BMI of 30, how much of those centimetres that you are measuring is actually her and not the baby? Same way, if she is measuring, if she's got BMI of 20 and you're measuring her, it'll all be baby. So there could be an element of discrepancy there. The other thing to think about is I'm 5'6". I've got a fair size BMI. My husband is 6 foot, and I had a baby that was 3.4 kilos. That's good, right for me. My best friend is Chinese. She is 5 foot. She has a very low BMI. Her husband is 5'5", and if she had a 3.4 kilo baby, that baby would probably be really big for her. And in fact could be indicative of things like diabetes, etc. Whereas her having a 2.2 kilo baby is probably the right size for her. Whereas if I had a 2.2 kilo baby, that baby would be too small for me. So what have we done about this? Well, we've taken the mother's information, her BMI, her height, any previous other babies she's had, and we've plotted a growth chart, predicted growth chart, based on those factors for her baby. And each time we measure her abdomen, we plot it on her graph. As long as the baby follows any one of those growth lines, whether it be the 5th centile, 25th centile, the 50th centile, the 95th centile, we are happy. If the baby moves, their growth alters off any one of those lines, we know that either that growth is being impaired, in which case what is happening to stop that baby's growth, or being excelled, and is that from a different condition? And we can look into things more accurately from there. These only work on women who have BMI under 35. If the BMI is over 35, because there is so much more mum, this is not at all accurate, and we rely on irregular growth ultrasound scans to monitor baby's health. Okay, so now we know where the fundus is and we've measured the fundal height. We're now going to move on. The next part of the palpation is looking for the lie. So for this, we do a lateral palpation. During the lateral palpation, we use 2 hands. You take the left hand and hold the abdomen steady whilst moving the right hand down the length of the abdomen. You're trying to see if you can feel either smooth line, which would be the fetal spine, or the bobbly bits, which are going to be your limbs. You then reverse your hands and do the same with your left hand. Again, feeling for either your spine or your bobbly bits. Once you find, I know it's not a technical term, bobbly bits, but it does feel like that. Once you find where the bobbly bits are, you can ask the woman, where does she feel most of her kicks and her movements? And that should correlate with where you think the limbs are. If the spine is in line with the maternal spine, as in the baby is going straight down, then that will tell you that you've got a longitudinal line. If the baby is lying across the abdomen at right angles to the spine, then you've got a transverse lie, and oblique will be the baby in the diagonal. We then move on to a pelvic palpation. Pelvic palpation, again, you're using 2 hands. With this, you're trying to find which part of the baby is actually in the pelvis. So you're looking for the presenting part. Is it cephalic, as in hard and round, the head, or is it the breech, which is more squishy and narrower? You'll also be able to see what the attitude is. Is the head tightly flexed, or is it wider and deflexed? We then need to have a look at the position of the baby. So when we're looking for position, we're looking at the relationship of the occiput with the pelvis. Now, again, lots of words, but what does that mean? Well, we can't actually feel for the baby's occiput. That's going to be quite difficult in some positions. But we know that the occiput is in line with the spine. And it's quite easy for us to be able to feel the baby's spine. So we're looking for a spine to be like a nice smooth edge. So we look at where the spine is in relationship to the pelvis. So if when you're palpating the mother, you can feel the spine uppermost, so the smooth area uppermost, you know that that occiput is anterior. If you can't find the spine at all, and all you can feel is all knobbly bits, okay, when feeling that mother's abdomen, all you can feel is limbs, well, that means that that occiput is posterior. So that baby is lying what we call back to back. So the baby's back is touching mum's back, and all you can palpate are the hands and fingers and toes and feet and knees and everything that's in front of the baby. If you can feel the baby to the side, the spine of the baby to the side, either left or right, well, then we're looking at lateral. If you can feel it kind of to the front, but not totally to the front, it could be what we call right occipito anterior, left occipito anterior, ROA or LOA. It means that it's not directly in front of us, as in occipito anterior, but the spine is just to one side. This will be a lot clearer when we come into the biosci lab, and we'll be able to show you with a model, be able to palpate these, and it'll make a little bit more sense to you then. Now we're looking at the engagement of the head. So how much of that head is actually entered into the pelvis? Well, the pelvic bone is firm, and obviously we're not going to be able to get our hands right in there to see how much of the baby is in there, but we do a bit of maths. So we split the baby's head into five fifths. How many fifths of that baby's head can you feel outside of the pelvis? It's one of those things that comes with experience. The more women you're able to palpate and touch, the more you'll be able to figure out more with a better accuracy. But for me, I know that each of my fingers is roughly just over 1 centimetre, and that's kind of like a fifth of the baby. So if I'm able to get 3 fingers around that baby's head when I'm palpating with 2 hands, then I know that I've got 3/5 palpable, which means 2/5 of the baby's head is down into the spine. Down into the pelvis. One thing you will see when you do eventually get out onto placement is the Porlick's grip being used. This is way too painful, and this is definitely a no-no. You do not use one hand when you are palpating. Always use 2 hands. Auscultation, the last stage of us doing this abdominal palpation. Listening in to the fetal heart. We always listen in through the anterior shoulder. Now that goes totally against everything you've ever done when it comes to listening to a heart. You're listening through the chest, surely. However, in the position that the baby is in, to listen in through the baby's chest wall, you would have to listen in through arms, feet, fingers, hands, toes, everything in the way. Whereas you've got a direct route to the baby's anterior shoulder. So that's where we listen into. On the screen, you'll see 2 different methods of listening in. The one is the sonicade, and mum can hear the baby's heartbeat with that. The other one is a pinard stethoscope that the midwife will use onto the abdomen. There is a reason why we use the pinard stethoscope rather than the sonicade, and that's because you cannot pick up maternal heartbeat with the pinard, but you can with the sonicade. And sometimes if mum is anxious and her heart rate is over 100, it can be mistaken for being baby's heart rate. A baby's normal heart rate is between 100 and 160, but when the baby is active, that can go a little bit higher. I've got a sonicade for you to listen to now. There is a definite difference between baby's heartbeat sound and mum's heartbeat sound, but I just want to show you how easy it would be for us to mix up the 2. That's the mother's heartbeat. And that's baby's heartbeat, a lot faster. However, if mum's heartbeat was around about the 100 mark, and this baby's heartbeat we know has been about 140, it'd be quite easy to mix the two up. And if we had a baby that had passed this stage and had died, then we could be thinking we're picking up the baby's heartbeat, when in fact we're picking up mum's anxiety. So, do we listen in or not? Well, listening in only tells us if the fetal heart rate is there at that normal range at that time. It doesn't tell us if there's been any distress or if there is going to be any distress. The other thing is, like I said, could very easily be mixed up between maternal heart rate and fetal. So, how can we tell if there is any stress of the fetus? I just want you to have a little think about man flu. Now, we know what they're all like when they have man flu. Pretty much like this. They curl up in the corner and they don't move. When the baby is distressed or something is causing it any harm, the baby will do exactly the same thing. This baby will sit in the corner, go quiet. The fetal movements will become slow. Or the fetal movements may become extremely active and be all over the place because this baby is going into a panic mode. Something's upsetting it and it doesn't like it at all. So what we're looking for is normal movement. And normal movement is different to every woman. We used to tell women to do the Cardiff Count to 10. Now, this was an all UK scheme. And it was found that there was a correlation between fetal well-being and activity. So we'd ask women to count 10 movements. And once they had their 10 movements, they knew their baby was fine that day. We used to even give them charts to colour in, so they'd colour them in when they had their 10 movements. The problem is one woman would wake up in the morning and count her first 10 movements. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That baby was really active that morning. And then didn't count any more movements for the rest of the day. The next morning, she got up, carried on with her day, and by about 5 o'clock in the evening, was starting to think that she hadn't had any of her 10 movements. That evening, she rang the hospital. And the hospital said, well, come in and we'll see what's going on. When they went in, that baby had gone. That baby had been gone for over 24 hours. So what we ask women to do now is, what is their normal pattern? My baby might have been really, really active in the mornings, and then we had slower movements in the afternoon. But that's okay, that's normal for my baby. My friend's baby just moved every hour, a little bit of movement every hour. That's normal for hers. Another friend's baby might have moved all evening, didn't feel anything in the morning, but come the evening, that baby wouldn't keep still. That's normal for her. But when that pattern changes, that's when we want the women to come into us so that we can see what's going on. Either by doing a cardiotocograph monitoring, which is a long tracing of the heartbeat, or by doing an ultrasound scan, or sometimes both. But what we're looking for is normal movements. So when you get to your exam and you have to speak to a pregnant woman and you're asking all their history, you must always ask, how are the fetal movements? Are your movements normal? So just a quick recap of I-FLAPT, and we will be there on the day to go through the models for you to have a go at doing the palpation. But this is what I-FLAPT was. Inspection, any scars, rashes or marks that aren't normal. Fundal height measurement from the fundus to the symphysis pubis, and make sure that that is plotted on a personalised chart. Lie, is the lie of the baby longitudinal, being following the maternal spine, transverse, lying across at right angles to the maternal spine, or oblique in the diagonal? The attitude, is that baby's head flexed or deflexed? The presentation, What is the presenting part? Is it cephalic, the head, or breech, the buttocks? Position. Is that baby's back anterior or posterior? To the right, to the left? And engagement. How much of that baby's head is engaged into the pelvis? How many fifths are we able to feel? Got some further reading for you to have a little look at if you fancy having a little look through some more bits and pieces before we see you over the next 2 weeks. And I'll now see you over when you get to the Biosci lab. Take care all.